The decision to utilize jet ventilation is usually recognized as first intention to prevent lung injury, or as a rescue to treat lung injury. There is no major agreement in research or across neonatal intensive care units about which approach is superior. The first intention approach is often utilized in extremely premature infants who are at very high risk of developing lung injury due to mechanical ventilation. This strategy aims to prevent lung damage from developing. Recent research has shown reductions in the development of bronchopulmonary dysplasia compared to volume ventilation, however, this is limited to a single center. The rescue approach is considered when an infant has not responded to traditional mechanical ventilation, and continuing the current method is highly likely to be ineffective or lead to lung damage. The high-frequency jet ventilator is unique because it utilizes high ventilator rates, small tidal volumes, and passive exhalation and functions in tandem with the conventional ventilator. The desired oxygen is set on the jet and conventional ventilator, so it is important to ensure that the set oxygen on both machines match. This method of mechanical ventilation can enhance carbon dioxide elimination and utilize low airway pressures to minimize the risk of lung damage. Just like other forms of mechanical ventilation, mean airway pressure is the main driver of oxygenation. Selecting an appropriate mean airway pressure is a fine balancing act. If the alveoli are not adequately inflated, perfusion cannot occur. If the alveoli is overinflated, it can obstruct the lung capillaries and impairing perfusion as well as damage the alveoli. One of the major benefits of the jet ventilator is the ability to optimize mean airway pressure but use a small tidal volumes as to prevent overdistension and lung damage. The level of PEEP has a major effect on the value of mean airway pressure. The true definition of mean airway pressure is simply the average pressure in the lung during ventilation as calculated in this formula. PEEP is set on the conventional ventilator. However, PEEP on the conventional and jet ventilator may provide slightly different values. This is because each ventilator is taking the measurements at different parts of the circuit. If there is a difference in PEEP of greater than 1, the circuit and expiratory valves should be assessed for condensation and the patient should be evaluated for air trapping. Adjustments to the PEEP will directly change the mean airway pressure. One strategy to find optimal PEEP is to set the conventional ventilator to CPAP mode, then monitor how the patient responds. If within 1 to 5 minutes the pulse oximetry drops, then PEEP is inadequate and should be increased by 1 to 2. This test could then be repeated, but only while giving the patient time to recover and the pulse oximeter to return to baseline. If the pulse oximetry remains constant in that 1 to 5 minutes, the PEEP and mean airway pressure are adequate and should be left constant while attempting to wean to oxygen as tolerated. The patient's oxygen requirement and pulse oximetry reading determine if the PEEP and resulting mean airway pressure are adequate. If the oxygen requirement is over 50% or the pulse oximetry readings are less than 85%, then the PEEP and mean airway pressure may not be adequate. If the mean airway pressure is too low, the first step is to initiate sigh breaths to recruit underinflated alveoli. Next, the mean airway pressure can be increased by raising the PEEP by 1 to 2 while keeping the PIP constant. This will increase the mean airway pressure. If there are improvements in pulse oximetry and reduced oxygen requirement, the mean is optimized and should be maintained until the patient's condition changes. If the oxygen requirement is over 50% or pulse oximetry is less than 85% with normal inflation or air leaks, the mean airway pressure can be increased by 1 to 2 until there are improvements. The mean airway pressure may be too high if the patient develops cardiovascular compromise, like decreased blood pressure. In this case, the best option is to obtain a chest X-ray to assess inflation. If a chest X-ray is contraindicated or not an option, the jet rate should be lowered to 240 to 300. If there are still no improvements, the mean airway pressure should be reduced by lowering the PEEP by 1 to 2 and waiting for 5 to 15 minutes and observing for improvements in blood pressure and pulse oximetry. During this time, if the pulse oximetry drops, the mean airway pressure should be increased as the mean airway pressure has dropped below the required level. After the optimal PEEP and mean airway pressure have been determined, the mean airway pressure should be maintained and the oxygen delivered should be slowly weaned. To manipulate oxygenation, the mean airway pressure should be adjusted for changes in the PEEP level. However, when making changes to the PEEP, it is important to monitor how the change will affect delta P and ventilation. The tidal volume delivered by the jet ventilator is typically smaller and delivered faster than high-frequency oscillatory ventilation. Ventilation is the transport of carbon dioxide through the respiratory system. The jet is extremely efficient in removing carbon dioxide from the lungs, and small adjustments can result in major changes. The jet ventilator controls ventilation through the difference of the PIP and PEEP, or delta P. Jet ventilation differs from conventional ventilation for carbon dioxide removal. In conventional ventilation, if the carbon dioxide level is too low, the PIP alone could be reduced, or if carbon dioxide is too high, the PIP alone could be increased. During jet ventilation, carbon dioxide levels can be increased by reducing the delta P. Alternatively, carbon dioxide levels can be decreased by reducing the delta P. However, changes to the PIP will result in inadvertent changes in the mean airway pressure. So when weaning or increasing the delta P, the PIP and PEEP need to be considered together as the delta P to maintain the same mean airway pressure. If the mean airway pressure is inadvertently reduced, this could reduce oxygenation. The higher the PIP, then the more it contributes to mean airway pressure. To avoid excessive PIP and the resulting potential lung damage, the PEEP should be adjusted. For ventilation or the management of carbon dioxide, the delta P should be adjusted through the PIP and PEEP to maintain a constant airway pressure. If the carbon dioxide levels are low, the first step is to decrease the PIP. If unsuccessful, then the rate should be decreased. If these steps are unsuccessful, ensure that the inspiratory time is at 20 milliseconds if it was previously adjusted. If none of these are successful, the PEEP could be increased as the mean airway pressure may not be optimal. However, keep in mind that adjusting the PEEP will change the delta P and should also be adjusted accordingly. If the carbon dioxide level is too high, the PIP should be increased while leaving the PEEP constant, which increases the delta P. Next, the inspiratory time could be increased. If these moves do not correct the issue, then the jet rate could be increased. However, if the patient is hyperinflated, lowering the jet rate would be more appropriate to correct the high carbon dioxide by extending the expiratory time. Lastly, the PEEP could be reduced while leaving the PIP constant. This would increase the delta P, but would also lower the mean airway pressure, which could affect oxygenation. While the jet ventilator utilizes high respiratory rates, the rates are generally lower than high-frequency oscillatory ventilation. When rate changes are made on the jet ventilator, they should occur in increments of 60 for each move. The inspiratory time is typically set at 20 milliseconds and is not routinely changed as it can easily lead to air trapping. By setting a consistent I time, the rate will determine the I to E ratio and exhalation time. Exhalation on the jet ventilator is passive, meaning it is dependent on elastic recoil. This requires the rate to be lower than the high-frequency oscillatory ventilator to allow for an adequate exhalation time. Patients can spontaneously breathe during jet ventilation as the conventional ventilator is also supplying a constant flow of gas. The rate on the jet ventilator is similar to conventional ventilation in terms of management. Increasing the rate will increase the amount of carbon dioxide eliminated so long it does not cause air trapping. Decreasing the rate will extend the exhalation time and which may improve gas exchange if air trapping is present. The inspiratory time should remain constant at 20 milliseconds. However, some patients may benefit from longer inspiratory times. Increasing the inspiratory time can lead to small increases in tidal volume, which could benefit patients with longer inspiratory time constants. If increasing the PIP has been ineffective, up to pressures of greater than 35, for controlling high carbon dioxide and all other settings have been optimized, the inspiratory time could be increased. If the inspiratory time is moved, it should be in increments of 0.004 to 0.006 seconds. The jet rate may need to be lowered to maintain a constant I/U ratio if gas trapping occurs. Air trapping is a valid concern during any method of mechanical ventilation. Air trapping can be easily identified with chest radiography when the lungs appear inflated beyond the level of the 9th rib. It can be identified without a chest X-ray when the arterial level of carbon dioxide rises despite appropriate increases in PIP or airway pressure amplitude, which would normally reduce carbon dioxide. Air trapping can lead to numerous complications like the development of air leaks, such as pneumothorax and pulmonary interstitial emphysema. Air trapping primarily occurs when there is not enough time for exhalation for a breath before the next breath begins. Since the jet delivers respiratory rates in the hundreds, air trapping is a valid concern. In conventional ventilation, when air trapping is present, the PEEP is decreased. During jet ventilation, when air trapping is present, the first strategy is to remove the sigh breaths, if present. Next, the jet rate is decreased. This would allow more time for exhalation. Choke points may occur when the airways lack structural strength or gas is being removed from the airways, resulting in collapse. During jet ventilation, an adequate level of PEEP will act to split the airways in the open position. Sigh breaths are utilized to prevent atelectasis. However, overuse of sigh breaths can lead to volume trauma, air leaks, and delayed healing of current air leaks, so it is important to justify when sigh breaths should be added. When atelectasis or overdistension occurs, there is a greater mismatch in ventilation perfusion ratio, leading to worsening ventilation and oxygenation. Optimizing mean airway pressure will optimize both oxygenation and ventilation. When a patient is transitioned from conventional ventilation to the jet ventilator, sigh breaths can be added initially as a recruitment strategy. After a few hours and appropriate recruitment has occurred, they can be weaned down or removed. In extremely low-weight infants, sigh breaths may lead to volume trauma and pulmonary interstitial emphysema, so it is important to minimize their use in this patient population. Some patients may develop wandering atelectasis. A small number of sigh breaths can be added to help prevent this from developing. The sigh breaths can then remain in place until extubation, or may be continued daily for a predetermined period of time. If sigh breaths are weaned and the patient experiences more desaturations, this is likely due to inadequate PEEP and not the removal of sigh breaths. If the patient requires a high level of PEEP but cannot tolerate it due to cardiovascular reasons, a small number of sigh breaths could be added in place of PEEP.
The servo is a numeric representation of the flow through the jet circuit needed to establish and maintain the set peak inspiratory pressure. Instead of being set, the servo is a feedback display and can be used to represent changing lung dynamics. When the jet ventilator is initiated and the patient is stabilized, the jet ventilator will enter a learning mode and determine a baseline servo pressure, which will be displayed. There may be small fluctuations in servo pressures as the patient spontaneously breaths. Trending the servo measurement when no adjustments have been made to the settings can indicate changes in lung compliance and resistance. The jet ventilator will alarm high or low when there is a change of more than 20% above or below the baseline servo. An increase in servo pressures indicates that more flow is required to fill a space at the same peak inspiratory pressure. So, this means that for a given pressure, more volume is being delivered. This may mean that lung compliance is improving, or there is a leak in the system and gas is escaping. A decrease in the servo pressure indicates that less flow is required to fill a space at the same pressure. So, this means that for a given pressure, less volume is being delivered. This may indicate that lung compliance is increasing, or there is an obstruction in the system.
The humidification temperature is set at 40 degrees Celsius. Since the gas is heated and humidified at the ventilator, it will cool as it travels through the circuit to the patient to about 37 degrees Celsius. Circuit rainout or excessive condensation can lead to a loss of PIP alarm and can be minimized by using a heated wire circuit and keeping as much of the jet circuit as possible inside the patient isolette. The respiratory therapist can remove condensation from the tube by disconnecting the green nozzle from the life port adapter and lifting the circuit towards the patient box and expelling the water through the circuit into a towel. The jet ventilator provides numerous indicators that provide helpful information about the ventilator's operations. The ready button will light up to indicate that the alarms have been calculated, set, and active. When the ready button is not illuminated, the jet ventilator is considered non-ready, meaning the alarms are not active. The ventilator will enter non-ready mode by pressing Enter or Standby. When the ventilator is non-ready, the patient should not be touched because the ventilator is in a learning mode. In the learning mode, the internal processor are performing calculations and adjusting the servo pressure to achieve the desired settings. While in the learning mode, no alarms are active. Instead, they are being calculated and will be set when ready. When the ventilator transitions from standby, the monitored values will adjust almost sporadically. However, these variations should not alarm the provider as the servo is just fluctuating as it attempts to achieve the desired settings. Once the pressure has stabilized for 20 seconds, the ready light will turn on. This usually happens within 45 to 90 seconds, but can take up to 3 minutes. After the ready condition is achieved, the alarms are calculated at 20% above and below the servo pressure. Alarms can then be manually adjusted. Pressing Enter will recalculate all of the manually adjusted alarms. Patients are suctioned according to hospital policy but is only performed on an as-needed basis to prevent damage to the patient's airway. Introducing the suction catheter into the endotracheal tube interferes with the pressure monitoring, leading to numerous alarms and fluctuations in the delivered pressure which can harm the patient. To suction. First, press the audio paused button to silence alarms. Next, press standby to pause the jet ventilator. This prevents any alarms and errors associated with pressure fluctuations. Now suction according to hospital policy. Next, press Enter to resume the previous jet settings. When the ready light turns on, ensure that the settings are appropriate and the procedure is complete. When the ventilator enters the ready mode, the alarms are automatically set but can be adjusted by the user. As the patient spontaneously breathes, pressure monitoring fluctuation up to 5 above or below are common. The jet utilizes a red, yellow, green light system for alarms. Green indicates the ready mode. Yellow flashing is a medium priority alarm and indicates alarm limits have been met in the servo or map monitoring. When responding to these alarms, the patient should be assessed first for ventilation to ensure the patient is safe, then for any interventions that may be needed. Then the ventilator and circuit should be assessed. A red alarm is high priority and the patient should be immediately assessed for ventilation status. If there is any suspicion that the patient is not being ventilated, they should be immediately disconnected from the ventilator and manually ventilated. When there is an active alarm, avoid pressing Enter as it will put the ventilator back into a learning mode. When the ventilator enters the ready mode, the alarms are automatically set but can be adjusted by the user. As the patient spontaneously breathes, pressure monitoring fluctuation up to 5 above or below are common. The jet utilizes a red, yellow, green light system for alarms. Green indicates the ready mode. Yellow flashing is a medium priority alarm and indicates alarm limits have been met in the servo or map monitoring. When responding to these alarms, the patient should be assessed first for ventilation to ensure the patient is safe, then for any interventions that may be needed. Then the ventilator and circuit should be assessed. A red alarm is high priority and the patient should be immediately assessed for ventilation status. If there is any suspicion that the patient is not being ventilated, they should be immediately disconnected from the ventilator and manually ventilated. When there is an active alarm, avoid pressing enter as it will put the ventilator back into a learning mode. The loss of PIP alarm is activated when the jet ventilator is unable to deliver or monitor jet pulses. This alarm will activate when the monitored PIP has fallen 25% below the set PIP. The monitored PIP is 3. Or the monitored value for delta P is 2. Common causes of this alarm are leaks or disconnections within the ventilator circuit, malfunction of the pinch valve in the patient box, condensation in the tubing, suctioning without putting the jet in the standby mode, or the patient spontaneously breathing, crying, coughing, hiccuping, or needing suctioned. The loss of PIP alarm can occur while the jet is in the ready and non-ready condition. When in the ready mode, breaths will still be delivered to the patient and the alarms will be active. In the non-ready mode, no flow will be delivered, the alarms will not be active, and the patient will not be ventilated. If the loss of PIP alarm occurs in ready mode, the ventilator will deliver breaths based on previous established pressures. However, the monitored values or PIP, delta P, and mean airway pressure will be incorrect. It is important to not press enter or reset. This will clear the previous established values and put the ventilator back into the learning mode, and now the patient is not ventilated. Instead, the circuit should be investigated and patient assessed. If the loss of PIP alarm occurs in the non-ready mode, the patient is not ventilated and the alarms are not active. The flow and servo pressure will completely stop to protect the patient. The ventilator will not re-engage until the enter button is pressed. This will place the ventilator back into the learning mode and it will attempt to stabilize pressures. It is important to assess the circuit and patient before the ventilator is placed into the learning mode because if the error is not resolved, it will repeat until it is adequately addressed. The patient should be weaned as tolerated. Delivered oxygen should be weaned below 50 to 60%, then PEEP and PIP may be weaned as tolerated to a minimal setting with PEEP of 8 or less and PIP of 20 or less. The delta P should be weaned to a minimum pressure of 16 to 20 or less. If carbon dioxide is low but the infant is not ready for extubation, the jet frequency can be weaned. The patient also should have normal blood gases and resolution of any air leaks or pulmonary interstitial emphysema. The patient can be extubated to non-invasive ventilation or CPAP. The level of CPAP should be set at a level close to the map before extubation.